I'm the Division Director for General Medicine and Geriatrics. A great presentation today jointly from the Division of General Medicine and Geriatrics, the section of Geriatric Medicine and Gerontology, and also from the Division of Infectious Diseases. Our two speakers today, Sahebi Saiyed is an MD, MPH. The CMD that you read on the screen is for Certified Medical Director. She's an assistant professor of medicine. She has background and training in both family medicine, a graduate of the University of Alabama Huntsville program, and also in geriatric medicine, graduating from our Geriatric Medicine Fellowship. Her co-presenter today is Scott Fridkin, who is a faculty member jointly in the Rollins School of Public Health and the Department of Epidemiology, and also in the Division of Infectious Diseases. He has a broad charge of being in charge of antibiotic stewardship across Emory Healthcare and affiliated institutions. You may not know or understand that approximately 5% of the hospital discharges that leave Emory Healthcare go through a skilled nursing facility, and that nationally about 7.1 million individuals pass through a skilled nursing facility per year. So while you may spend a lot of your time training in a hospital setting or doing work in an outpatient setting, very important section of our healthcare facilities. You might not know that Emory Healthcare also owns a nursing home. The Bud Terrace nursing home facility on the Wesley Woods campus, skilled nursing and post-acute care, is Emory owned, and our faculty in general medicine and geriatrics are the medical staff for that facility and also for the AG Rhodes nursing home. So welcome to everybody to Grand Rounds, and Dr. Saiyed, you'll start us off. Thank you.
Thank you. Good afternoon, everyone. We are going to talk about antibiotic stewardship in nursing home. Does it pass the SNF test? SNF is a short form for skilled nursing facility. To help you relate better to the situation, I'm going to start with the case. We have an 85-year-old female patient with moderate dementia and arthritis. She was admitted to the hospital after a fall at home. At baseline, she was able to ambulate with the walker and perform her activities of daily living with some supervision. She was diagnosed with pelvic fracture, and orthopedic was consulted in the hospital. They recommended conservative management. Patient was in the hospital for 3 or 4 days, and at the time of discharge, she was found to be very deconditioned and unable to do her basic ADLs or ambulate. Therapy department evaluated the patient, and they recommended that patient goes to subacute rehab. Subacute, skilled, post-acute rehab, they all means the same. Acute rehab is different from subacute rehab. It is more intense rehab program where patients are required to participate with the therapy for at least 3 hours per day. Whereas subacute is less intense, and patients can receive therapy somewhere from 1 to 3 hours per day. Acute rehab is more like hospital setting where there is a 24-hour MD presence, and patients are required to be seen by attending MD every day. Subacute rehab coverage model is a little different, and after hours and weekend coverage is provided by the on-call physicians. The length of stay is typically shorter in acute rehab compared to subacute. And I would briefly like to mention the two facilities which we have at Wesley Woods campus, and Emory is closely connected with them. Bud Terrace Subacute and Long-Term Care Facility, as Dr. Johnson mentioned, that it's affiliated with Emory Healthcare, and it has 250 beds for subacute care as well as long-term care. The other one is AG Rhodes Subacute and Long-Term Care, and it has 150 certified beds. And at both the places, the medical coverage, medical care is provided by our geriatric division. So going back to our case, patient was discharged to subacute rehab, and patient was receiving her rehab. On day 10, family concerned about the foul smelling and dark urine. And this was reported to the nursing staff. Nurses goes and evaluate the patient. Vitals are normal. Does not have indwelling catheter. There is no change in condition except patient is slightly more confused. Daughter was insisting on UA, and the staff also now thinks that patient needs to have UA. They called the on-call physician, and they obtained the orders for UA and urine culture. Patient was started on hydration protocol but no antibiotics were started. After 2 days, the regular attending physician comes in and looks at the labs. They see that there's a positive urine culture, more than 100,000 colony-forming unit for this patient. Patient was evaluated. Patient was stable with no fever or no urinary symptoms, no other constitutional symptoms. And in fact, mental status was improved with hydration. So this was probably the case of mild dehydration, which improved with the oral hydration protocol, and a case of asymptomatic bacteriuria. So the big question we are trying to answer here is, are there any minimal criteria that should be considered prior to initiating labs and antimicrobial treatment for suspected urinary tract infection in SNF or long-term care setting? And at this point, I'm going to turn over to Dr. Fridkin, who has helped us build the antibiotic stewardship program at Bud Terrace, and he will help answer this question. Thank you.
Thank you very much. Happy to be here. We thought we would sort of take now a little bit of a 40,000-foot view about really what's going on nationally with skilled nursing facilities and a real push to start antimicrobial stewardship programs in skilled nursing facilities nationally. And so to do this, we thought we would highlight some of the consequences, the bad consequences of unnecessary antibiotic use in skilled nursing facilities, define what we mean by antimicrobial stewardship, as well as demonstrate how focusing on urinary tract infections is really an ideal place to start at Bud Terrace. So this is a question that many of you in the audience may be familiar with, may have your own understanding of what we mean by it. But basically, antimicrobial stewardship is trying to get the right dose to the right patient for the right reason. There's a lot of different ways to go about doing that, and the challenges for implementing it in different facilities will vary based on that facility. But really, it's about patient safety. It's about doing the right thing for patients and delivering the highest quality health care we can. So it's something we've all been trying to do, but we didn't really have a name for it over the past decade, especially in skilled nursing facilities. The question has come up over the past 5 years or so, is it really needed in skilled nursing facilities? Do we need to have antimicrobial stewardship programs? And really, we worked hard to make a case for this. Clearly, the number of residents in skilled nursing facilities is increasing over time. 70% of residents in a skilled nursing facility receive an antimicrobial in a given year. About 20% are actually on an antibiotic at any given time. Often these antibiotics are prescribed empirically without real confirmatory culture data or definitive clinical syndrome. And there's been some published literature, mostly based on single institution studies, that estimate around 40 to 75% of antibiotics that a nursing home resident may be on really is either having the wrong dose, the wrong indication, or the wrong duration. There's a lot of published data to give sort of a national perspective of what's going on in skilled nursing facilities, but it still begs the question, is our facility different? And so on the left side of this slide here are some of the sort of published data around why antibiotics are being used in skilled nursing facilities. So the most frequent indication for an antibiotic is a urinary tract infection. About 40% of treatments that occur in some of these national or single institution studies are really directed at abnormal urinalysis. In some of these studies, they identified that about 2/3 of the time the duration of antimicrobial therapy for UTIs was too long, and 50% of the time the antibiotic was wrong based on the susceptibility of any pathogen that was recovered. The second most common syndrome is respiratory infections. And in some of these published studies, around 19%, no antibiotic was really indicated because the patient didn't have a clinically relevant bacterial infection, or what would have been a bacterial infection. On the right side of this slide is an assessment that we did together with our colleagues in Bud Terrace, looking at why antibiotics are being used at Bud Terrace. And this was using data from January through June of 2017. So about 2/3 of the antibiotics were new antibiotic starts at Bud Terrace. And amongst those, UTI was the most frequent, just like is seen at the national data, about 38% of all starts. And about 1/3 of the time, it was directed at an abnormal urinalysis without symptoms to suggest a urinary tract infection. 90% of the time, the antibiotics, the duration of therapy was 5 days or greater, the median duration being 5 days, which is by some standards considered too long. Respiratory infection was second, similar to the national, and about 12% of the time those patients did not meet a accepted definition of a healthcare-associated respiratory infection, bacterial infection. So things are similar, bud tears, as we've been seeing with some of the published literature from nationally. And then it begs the question, what are the consequences of receiving unnecessary antibiotics if these residents are receiving it? And again, most of this comes from some published literature nationally, and we can anticipate these same things may be seen locally as well. So the first adverse event is adverse drug events or interactions. They're very common in this patient population. Antibiotics are associated with 13% of the adverse drug events that have been reported in some published studies, hypoglycemia being one of the most common ones. Antibiotic resistance has been a big concern, but it's also one that's easily talked down for the relevance for any one individual resident. However, when we've done some carriage studies in skilled nursing facilities elsewhere, not at Buteris, but in other places, we found incredibly high carriage rates, colonization rates with the residents, between 20 to 80%, depending on the pathogen that we're focusing on. MRSA being the most common, more than VRE and more than carbapenem-resistant Enterobacteriaceae. So the carriage with multi-drug resistant organisms is fairly high, and any antibiotic exposure these patients have that's unnecessary will just prolong that carriage and, again, facilitate transmission and amplification in those facilities. This is a particular concern, and we'll come to this in a subsequent slide, in that what's happening in these skilled nursing facilities is going to happen now in our acute care setting. So we need to pay attention and try to have an impact there. And then finally, probably what was resonated the most to build momentum in stewardship programs in skilled nursing facilities is the risk to the individual resident for developing Clostridium difficile infection. So this has been probably the most patient-centric argument to avoid unnecessary antibiotic use. There was a nice published study in Canada looking across a large number of nursing homes and finding that residents in nursing homes that had what was deemed high antibiotic use overall had 24% greater risk of developing C. difficile diarrhea compared to antibiotics that had overall low antimicrobial use, sort of an ecologic assessment. From the CDC's Emerging Infections Program, they've estimated over 100,000 cases of C. difficile infection occur in nursing home residents in a given year. And a quarter of these ended up in the hospital within 7 days of that infection. 8% of those patients died. Most of these nursing home onset C. difficile infections were among residents who had received antibiotics. So 75% had received antibiotics in the prior 12 weeks. The risk of acquiring C. difficile has been quantified in some studies. The risk of C. difficile diarrhea is 8-fold higher for nursing home residents that have been treated for the urinary tract infection compared to comparable residents. Do I have to do that? So specifically around C. difficile, in some of these studies, the risk for C. difficile at a patient level has been highest with preceding exposure to fluoroquinolones. That's not universal, but that's been very common in the U.S. And is driven by the types of C. difficile strains that are circulating. So when we focus in on fluoroquinolones, this is an antibiogram of the Buteris urinary isolates that we put together as part of this initiative. And focusing on E. coli there for ciprofloxacin, we see 60% susceptibility of the E. coli residents to ciprofloxacin. Highlighted there in blue is the Buteris susceptibility being 60%, like I said, and for some other studies like the urinary isolates that are reported to CDC from about 100 skilled nursing facilities reporting to the National Healthcare Safety Network, for there it's a susceptibility of about 50%. So this is not uncommon to have fairly low susceptibility to quinolones among urinary isolates in skilled nursing facilities. And with our colleagues in other parts of the country, everyone's seeing around 50 to 60%. So the bottom line is most urinary tract pathogens are not universally susceptible to levofloxacin, even though it is the most commonly prescribed antibiotic at Buteris. So we think that stewardship makes sense. there's a lot of unnecessary antibiotic use, and there's some harm that comes from unnecessary antibiotic use. Stewardship's now a requirement. So all of this information, all this momentum led to CMS revising their conditions of participation, and as of I think it was October of last year or January of this year, all skilled nursing facilities that are registered with CMS need to have a antimicrobial stewardship program as part of their infection prevention and control program. They define what an antimicrobial stewardship program is loosely. Basically, they have to have antibiotic use protocols and also to monitor antibiotic use. They refer to the CDC's core components of what a stewardship program is for skilled nursing facilities for more information on how to develop one. And so briefly, what these core components are, they reflect directly what is also required in acute care facilities, but there's a lot fewer staff members to contribute and participate in such a program. There's not a very deep bench in skilled nursing facilities to come up with individuals that provide leadership, commitment, accountability, having a single person responsible for the program. Having drug expertise is probably the biggest challenge, relying on consultant pharmacists that have the antibiotic expertise to provide some input to the program. Defining what's the best action, starting very small and sort of escalating it over time is sort of what seems to be working in facilities that have taken this on. And then tracking antibiotic use is starting from scratch. There's mostly just paper forms of what antibiotics are being used. They don't have the same tracking systems we have in acute care. Reporting back to providers can be challenging too, as providers cross over to many different skilled nursing facilities. And providing education in this setting is different from how we do it in acute care as well. So there's challenges to achieving all of these core components, and the approach needs to be refined and reflect what's going on locally. This was difficult for me until I started spending some time at Bud Terrace to recognize just how different the challenges are around antimicrobial stewardship in skilled nursing facilities compared to the acute care setting. I mean, the residents are very different, particularly impaired communication, difficulty in obtaining specimens, and the family concerns than we may see in acute care. System factors including the lack of continuity, limited diagnostics, and most particularly staff turnover has been particularly challenging as facilities have tried to build these up nationally. And then provider factors, the reliance on telephone ordering and limited direct evaluation and lack of access to information at a time of decision making. These are all challenges that a stewardship program cannot fix them all, but there's at least some that I think a basic program can address, and that's what we've tried to do. So why is Emory University Hospital and some of our staff trying to build this program in Bud Terrace and potentially even more facilities? Because we share patients, that's the bottom line. We have a lot of experience in improving healthcare quality around antibiotic prescribing and around infection control that can translate into these settings. Collaborations already exist to reduce readmission rates, and this is just an extension of that. And regional collaborations involving the state health department and trying to collaborate between acute care and skilled nursing facilities, something that they're trying to build, and hopefully this will grow over time. There's also emerging activities, expertise to identify and support stewardship. There's more experience being gained in acute care settings for how to do this through some more advanced informatics and telestewardship opportunities. There's also existing educational resources for staff and family that are being tailored to this type of environment. Just to highlight again the importance of this of patient flow, this is a cartoon of what was actually a pretty advanced mathematical modeling exercise that CDC did, and using data from Orange County, California, emphasizing and illustrating the importance of sharing of patients across skilled nursing facility and acute care facilities, and how by communicating and coordinating a response to the emergence of an antibiotic-resistant pathogen, you can reduce the transmission and prevalence of this in all facilities, as opposed to just acting alone and responding to your own data. This is a practical example of that. These are data from the Chicago area. This is for the spread of carbapenemase producing Enterobacteriaceae in the early stages of their epidemic. Each of these dots or nodes in this social network analysis represent a different facility. The red facility in the center is a long-term acute care center that was the epicenter of disseminating this CRE pathogen. Each of the green dots are long-term care facilities, and those arrows represent the 3 long-term care facilities in that area that shared 30% of the cases. So 30% of the transmission was really linked to long-term care, even though the emphasis of their investigation really focused on this one LTAC as sort of the disseminator and the amplifier. The whole outbreak was propagated by long-term care centers that are affiliated with multiple different acute care centers. Only 10% of the patients in this epidemic acquired their CRE from an acute care center. And then this is an interesting slide that we actually now have grabbed all the data from the 8-county metropolitan area here in Atlanta and looked to see where the Medicare patients are going. And so each of the boxes and circles here represents a facility. The circles are hospitals, and the boxes are long-term care facilities. The blue are Emory healthcare acute care facilities. At the 3 o'clock level is Emory University Hospital. The reason it's at 3 o'clock is it is the most connected to all of the other facilities in this 8-county area. So we admit and discharge patients to other facilities more than any other facility in this 8-county area. Next to that is Midtown Hospital, then Piedmont, and then St. Joseph's Hospital. So the point here is that Emory University Hospital is very connected to other hospitals, but also to the long-term care community around the area. And then finally, antibiotic stewardship implementation works. The data to justify this mostly is in reducing unnecessary antibiotic use. A systematic review of 14 studies assessing programs in nursing homes revealed 8 of the studies showed a decrease in the overall indication-specific antibiotic prescribing. So they're able to get people to prescribe antibiotics for the right indications more of the time. 10 studies reported improved adherence to established guidelines. None of them showed any increase in mortality or hospitalization as a result of lower antibiotic use. However, there's really very few studies that show the impact on C. difficile rates or antibiotic resistance. So this is still a gap in knowledge, is demonstrating exactly what components of a program lead to these other additional better patient outcomes. So regarding urinary tract infections, why do we think this is really low-hanging fruit? And so this is just an emphasis of bringing us back to the case now. Some of these skilled nursing facilities are very large. If we had a 500-bed skilled nursing facility, the question is how many residents would have a UTI requiring an antibiotic? Based on prevalence assessments, about 40% of residents at any one time will grow bacteria in their urine, some up to the level of having what we may call a urinary tract infection based on just laboratory criteria. But only 1 to 2 of these patients will have symptoms with that and have a symptomatic UTI and really require treatment. So there's really a preponderance of presumed UTIs based only on laboratory data, and avoiding unnecessary antibiotic or urinalysis and urine cultures is really one of the hallmarks of a good stewardship program in skilled nursing facilities. So part of this includes education to all the providers in these facilities, and this is a few slides just emphasizing the importance of appropriate diagnosis of a UTI in skilled nursing facility residents, that it requires symptoms and objective findings, and not just objective findings alone. Symptoms are based on resident assessment, and a UA and a urine culture only provides supportive evidence. They're not helpful without signs or symptoms. You can't really interpret them without signs and symptoms. So it's the presence of signs and symptoms of bacteria and bacteriuria that indicates an infection is present. There's been many trials in this population that show treatment of asymptomatic bacteriuria is just not indicated, even though it's fairly prevalent. Treatment has no effect on morbidity and mortality. The symptoms of chronic incontinence and acute episodes of UTI remain unchanged. And the negative consequences we've already talked about. So there's been a lot of push with these stewardship programs to implement a better assessment of the presence of symptoms, to somehow put that into the process of care and apply some standardized criteria for starting antibiotics and for ordering diagnostic tests. And these were promoted first in 2001 by Dr. Loeb in Canada, and these Loeb criteria are sort of laid out here in a cartoon fashion. So the way to move forward and try to standardize the approach of approaching a patient that may have a UTI in skilled nursing facility is to incorporate these modification of these Loeb criteria to the routine assessment and practice of care in the facility. And the approach to a patient with a urinary catheter and without a urinary catheter may differ, but there can be a systematic application of the presence of symptoms for either of those two patient populations, as they're sort of laid out here. In addition to standardizing this approach by using these modified Loeb criteria and asking the nursing staff to assess the patients in a similar way, is to educate all the providers on this process and have them buy into this process. The best way to do that is to bring local data to the process. What's our antibiogram, how our first choice of therapy is appropriate for that antibiogram, and finally to track progress and feedback data on how well each of the providers are doing in applying the Loeb criteria, in avoiding unnecessary diagnostic tests and unnecessary antibiotic use. So that brings us basically to applying that process to bud terrace. And so Dr. Saiyed will come back and explain to you exactly what the program now looks like.
So based on the information we had from our quality initiative, we were able to establish the best practice and recommendations regarding the diagnosis and treatment of urinary tract infection. So the main goal here is to provide our patients with the best care possible and to avoid unnecessary urine testing and antimicrobial use. It should only happen when residents have UTI symptoms. So our program has 4 steps. The first step is assessment, where formal assessment of the patient will be done by the nurse. And here we have introduced the SBAR UTI tool for our nursing staff. Step 2, if the patient meets best practice criteria based on the assessment, then obtain UA, urine culture, and start the patient on empiric antibiotic and hydration. If they don't meet the criteria, then there will be close monitoring of the patient and patient will be placed on hydration. Step 3, if the antibiotics are indicated, we want our providers to start right drug first. Last step is when you have the more information, when you have the final urine culture sensitivity results, you revise or stop antibiotics. So the first step, SBAR tool. SBAR tool is situation, background, assessment, and recommendation format tool. It has been used in the nursing home settings and other variety of clinical setting. It's basically a communication tool between the nursing staff and the providers. And this is easy to fill out. It takes only a few minutes for the nurses to fill out. And it captures all the vital information what the provider is going to need to make the final clinical decision. So what happens whenever there is a change in clinical symptom, clinical status, which is suggestive of UTI, nurses will fill out this form. And the SBAR tool will help them guide their decision based on the presence of catheter, risk for complicated UTI, and the quantity of relevant symptoms which are based on Loeb's criteria. So in patients who have indwelling catheter, the criteria are met to initiate antibiotic or UA if they meet one of the following. If they have fever, new delirium, or blood pressure change, or rigors or chills, or they have severe UTI symptoms. In patients who do not have indwelling catheter, criteria are met to obtain UA, urine culture, or start antibiotic if one of the following situation is met. Situation 1, where they have acute dysuria or acute scrotal pain. Situation 2, where they are febrile and they have one new or worsening UTI symptom. Situation 3, where they don't have any fever but they have 2 new UTI symptoms. Based on that, nurses would be able to say whether the patient meets the best practice criteria or not. If the best practice criteria are met, then go ahead, opt in UA, urine culture, and start empiric antibiotic. If they do not meet the criteria, our stewardship program guidance supports watchful waiting with hydration and additional observation. In both the cases, nursing staff will communicate the criteria with the provider. So if they meet the criteria, we want our providers to start the right drug first. So based on our antibiogram and the national guidelines, we were able to come up with the best practice treatment recommendations. Our first-line drugs are nitrofurantoin and cephalexin. With the new revised Beers criteria, we can use nitrofurantoin if the creatinine clearance is more than 30. And cephalexin is pretty acceptable unless there is a documented severe penicillin allergy. You can make a day 3 switch if the organism is not sensitive to these drugs. The second-line drugs we have are doxycycline and Bactrim. Doxycycline has moderate coverage and it is pretty safe. Bactrim would require the renal dosing as well as you have to watch for the interaction with warfarin, creatinine, as well as potassium level. The third-line drug which we have is fosfomycin, which is just one-time dose, and it has good coverage if you are suspecting Enterococcus or Pseudomonas. And these are the treatment recommendations for UTI and cystitis, uncomplicated or complicated. For pyelonephritis, our first-line drug is ceftriaxone, IM or IV, and then you switch to Bactrim or fluoroquinolones. Nitrofurantoin and cephalexin, they balance safety and likelihood to be effective against our common UTI pathogens, so they were our first choice. And our fluoroquinolones was one of the popular drug among our providers, and we know that most of our pathogens are not susceptible to quinolones, so we really discourage the use of quinolones. Last step, based on day 2 or 3 data, you can revise your plan and stop the antibiotic or change the antibiotic as needed. And here is the table which gives the duration for the antibiotic. For most of the uncomplicated UTI, the treatment duration is from 3 to 5 days, except fosfomycin, which is just one-time dose. And for complicated UTI and pyelonephritis, the treatment duration is from 7 to 14 days. So in a summary, we have, at Bud Terrace, we have done 3 interventions. One at the patient level, where we have provided them with the education letter, which has education on UTI, as well as information on our best practice related to UTI treatment and diagnosis. We have done intervention at our nursing level. We have provided them education, as well as the SBAR UTI form was introduced. At the provider level, we have done education as well as provided them with the pocket cards, which has Loeb's criteria and the best treatment recommendation. We also have Antimicrobial Stewardship Committee now, and we had our meeting last month. Our first meeting was held last month. And in future, we hope to develop best practice recommendations for respiratory tract as well as skin and soft tissue infection, and monitor C. diff data, as well as improve our communication with the outpatient parenteral antibiotic treatment group. And that's it. Any questions?
I guess my question is, what are the consequences of somebody that is missing and not following the recommendations, or somebody comes back and repeatedly doesn't do that? How are you dealing with those?
For a provider?
Right.
We are given. So we have been monitoring our antibiotic use, and our director of nursing has been sending out this antibiotic reports every week. Based on that, I've been giving one-on-one feedback to our providers, and that has helped. So we haven't come across any situation where they haven't followed the criteria. But there were a lot of questions about, when we educated them, there were a lot of questions that why can't we wait and watch for patients when we are not convinced that it's fully UTI. And what we recommended them after talking to our ID expert, that based on initial UA, you can decide whether the patient would need empiric antibiotic or not, but don't spend 2 or 3 days waiting for the urine culture.
A great presentation. I was really struck by how connected Emory University Hospital is with multiple skilled nursing facilities. Do you think that our next step is kind of as a purchaser or collaborator, or is our next step to try and bring skilled nursing facilities together with a positive message? Do we think that there's an influence on the state? What do you think are next steps?
So I think it depends how successful. I mean, I think the work with Bud Terrace can demonstrate, and this is just the start of a program that we're trying to work closely together on. Demonstrating, I don't think we have to wait to demonstrate the impact of this. I think there's going to be improvement in guideline compliance, probably a decrease in therapy, overall antibiotic exposure, and in time we may see a decrease in C. diff rates. That would be wonderful. I think prior to that, reaching out to the facilities we're most connected to identify, offer, an evaluation of their program, and assess how interested they are in collaborating to bolster that. I think doing that in 1 or 2 or 3 scenarios might help build some momentum. The state, I don't know if anyone's here from the state. She did, excellent. Maybe you can come to a microphone and just summarize. The state's very, very active in both preventing healthcare-associated infections and in antimicrobial stewardship. And they actually have a dedicated pharmacist working at the state level to try to promote stewardship. And I think they would say that this type of collaboration is good, and ideally the state will help us reach out and work together with these facilities. Want to just summarize the role of the health department in this?
Sure. So
and introduce yourself.
My name is Shrina Advani, and I am the antimicrobial stewardship pharmacist that works with the Georgia Department of Public Health. And right now we have a few stewardship-related initiatives that we've rolled out in the acute care setting, including an antimicrobial stewardship honor roll that facilities apply for, encourages the facilities to implement all of the core elements, what have you. And we have some webinars that we also do on a monthly basis for pharmacists in the acute care setting. So what I'm hoping is that we can model that acute care stewardship from a state level to long-term care. And so actually we have a state stewardship subcommittee that's going to meet early April, and we're going to have Dr. Saiyed here present this information to our committee so that we can all collaborate and try and figure out what we can do from a state level to help the facilities, the skilled nursing facilities in our state to kind of bolster their stewardship programs and how best we can help from a state level.
Any other questions?
Okay. Thank you very much.
Thank
Appreciate
you.
it.